seizures. 60% of babies with spasms go on to develop other types of seizure and are ultimately diagnosed with epilepsy. And with infantile spasms, there is often developmental delay or regression of developmental milestones, which is an important piece of understanding sort of what the prognosis might be and sometimes clues us in on what treatments we should use. So spasms usually present between 3 months to 9 months of life, sometimes a little bit earlier and rarely a little bit later, with 90% of cases being diagnosed in the first year of life. So in the population, this amounts to 2 to 3 per 10,000 births worldwide per year, which means up to 2,500 new cases per year in the United States. So it is rare, but these are large numbers for our rare epilepsies. And so it's important for parents and pediatricians to be aware of this rare condition, because as I'm going to keep saying over and over again, early recognition and thus early treatment allows us to improve developmental and cognitive outcome and hopefully gain more control of the epilepsy earlier. So West syndrome is another term you'll hear related to infantile spasms. It's the eponym that we've used in the past for this condition. And it's named after Dr. William West, who is a British physician who first described the spasms in his son. So at 4 months, his son began having repetitive head nods and then more severe seizures, and he had developmental regression and then later on developed generalized convulsions. So West syndrome is actually a triad of the spasms themselves, which are the seizures, specific EEG patterns that go along with your background brain waves, so the in-between seizure waves we see on EEG, as well as the pattern during the spasms themselves, and then this developmental regression piece. But you don't need to have all three to have the diagnosis, but that's the classic triad. So the background EEG pattern specifically that you might read about if you come across spasms is something called hypsarrhythmia. And I want to show you the difference in brain waves between a normal baby EEG, which is sort of this, kind of multi-frequency, lower amplitude pattern of the EEG, which is normal, compared to this high amplitude chaos in the electricity of the brain on the EEG. That's hypsarrhythmia. That's the pattern we get concerned about because this is what leads to the developmental regression. So that's the term you'll come across, and it's the pattern in between the seizures themselves. So there are stages of how spasms present, and the first stage might just be some infrequent or isolated spasms. But as it goes on in the second stage, these increase in frequency and then begin to do that clustering. The developmental regression may initially just be kind of slow developmental progress or a plateau of the baby acquiring milestones, and then it becomes loss of skills. And then in the third stage, spasms themselves actually tend to decrease, but it's highly possible that other types of seizures emerge. And so that's really what we're aiming for, is to try to halt that process. And again, depending on why the spasms have come out in a child, it may not be possible, but it's our aim with aggressive treatments. So spasms are often confused with super common baby movements. Things like colic, reflux. Babies get very stiff and arch their backs and have a lot of jerky movements when they're uncomfortable with reflux or colic. And then the baby startle reflex is often this big extension of the arms with some movements like this. And so that can be confusing too. Now, what we often do when we see these and we're not sure is we'll need to do an EEG to figure out what they are. And so the idea behind that is actually capturing the movement of concern while a child's on EEG. So how do you differentiate, though, if you don't have the EEG? So clinically, there are some clues. The fact is that most of the time, reflux or colic won't cluster in the same way that spasms do, and the movements themselves might not be as stereotyped or repetitive in the same way. So again, like we talked about, the individual spasms themselves are very short. They're less than, about a second. But then the clusters themselves can last minutes, sometimes rarely even hours. And the difference as well with maybe some normal baby movements versus spasms is that spasms tend to happen when babies are first waking up or if they're falling asleep. So it's this drowsy state when the spasms tend to come out, which may not necessarily be what you're seeing with something like colic or a startle. And again, just some of the types of movements that kind of the way spasms are described are little crunches of the body, head bobs, or sometimes even just a subtle facial expression change. And I'm going to show you some videos of how subtle some of these can be. So hopefully we can get this video to work. Okay, I might have to, the playback is sometimes strange, so I have to get in here.
Just want to make sure you put enable content right to the right, Dr. McDonough.
Content.
On that cream colored bar, right to the right, way to the right.
So is it in the more? I'm so sorry to have a wrench in this. Share computer sound optimized for video sharing.
Let's see if it works.
Sometimes it's the PowerPoint that. Never a dull moment on Zoom.
No worries. We're used to this. We are a very relaxed group. You're fine.
Okay. Oh, here we go. Playback.
Playback. There we go.
Okay, play. Oh, come on, people. Oh, goodness.
You're fine.
These are some good videos. Any ideas?
Can you, is it possible to close out and go back into your slides?
Yeah, let's do that.
Okay. And go right back into it and see if there's that enable content that comes up again. Okay, right there. See that cream bar way to the right. Go right to the right and enable content.
Ah.
Yep. Now go ahead and try and play it.
Okay. Ah, here we go. So these are all from the Infantile Spasms project. This is a really great.
A disappointed Prince Harry speaks out. Why he's being pulled from combat. All today's news at 4 after Oprah.
You pick the worst time to have meaningless arguments.
Having this stereotype with a little bit of a facial grimace.
When it comes to you, yes.
See.
And this extension of his arm.
Why didn't you take it? See? I'm recording
And
it.
Tiffani's not altered necessarily, although some babies will get very irritable as the cluster of spots.
What do you mean work on things together?
What I mean is you came here, you distance yourself from.
But unlike something like colic, you know, that would be a little less stereotyped and, you know, may just become more progressively involving the body, whereas these are very short and stereotyped. There's another. The repetitive motion of the arm, and then a little bit of a subtle facial expression change, but this becomes more pronounced over the course of the cluster. And you can see that her eyes tend to get this other look in them with the movement. And sometimes spasms, you know, most of the time spasms involve the whole body, or at least both sides of the body, but not always. So sometimes, depending on the cause of the spasms, they can be unilateral or involving one part or one half of the body. Yeah, so this is a good example of one of these extensor spasms with he has lots of tone.
Okay. Hey boy. Okay, my boy. Okay.
The key with this one, I think, is just that it's very repetitive and again, stereotyped, right? So, he's moving around like a baby might, learning to sit, but it's this similar movement each time and the involuntary nature of it. Oops.
Well, you've got a couple of them. I mean, that's good enough. Let's see what she's reading.
He is doing it. And he only does it for a couple minutes, so.
She's on her way.
Okay.
I have to see that mom's trying to maybe it's trying to like suppress that. Can't. Very
He's doing it right now. He just started doing it. So I'm just recording it in case you missed it.
Oh, yeah, okay.
very stereotypic illness. A really important feature of this album.
Oh, yeah. You know, I know exactly what that is.
Yeah. All right. I'm gonna try to get back into my slideshow here. Okay. So I just wanted to touch on the causes of infantile spasms. There are many, but we sort of think of them in some ways when they are considered symptomatic spasms, meaning that they're related to an underlying identifiable condition. Sort of these categories that we think of in terms of the underlying cause. So in symptomatic spasms, many children may already have some sort of genetic diagnosis or some, MRI-based diagnosis. And the key often is that there's some sort of existing developmental delay prior to the spasm onset. And this accounts for about 60 to 70% of cases of all spasms. So in terms of prenatal causes, infections of the central nervous system, very important cause of spasms, tuberous sclerosis complex, which is something I'm going to talk a little bit more about in a bit. Congenital infections, such as your torch infections like CMV or Zika virus, toxoplasmosis, things that moms are tested for during their pregnancy. Genetic conditions, an important one is Down syndrome, but also more rare genetic conditions related to epilepsy. And then very, very rare inborn errors of metabolism. And those children present in the NICU being quite ill and having, very severe spasms. And they're ultimately diagnosed much of the time when they're in the neonatal intensive care unit. And then there's the category of perinatal causes. So one of our most common is hypoxic ischemic encephalopathy, which is an injury to the baby at birth. Again, I'm going to talk to you about that in a little bit. Or also babies who are born premature, but then have structural brain injury as a result of their prematurity. And then there are some postnatal causes. So baby doesn't necessarily have anything that's a risk factor related to their birth or prenatal history, but there's certain early infantile infections or even trauma can cause substantial enough injury to the brain where spasms emerge later. So tuberous sclerosis complex is a neurocutaneous syndrome, and it's a multi-system disorder in that it affects multiple organ systems. This accounts for up to 30% of our prenatally caused genetic structural causes of spasms. And what I mean by that is that the gene that's involved is causing some differences in the brain structure and brain networks, which is then leading to the cause of the spasms. So the main cause structurally within the body and the brain are these benign, many times benign tumors called hamartomas, as well as some other like low-grade cancerous tumors of the brain, eyes, heart, lung, kidney, and skin. And the MRI image I've got here is some of those tumors within the brain called tubers, which is where this tuberous or named after tuberous sclerosis. So there's very high rates of the development of spasms in patients with tuberous sclerosis complex, up to 70% of patients. Many patients go on to develop epilepsy that's hard to control. And so there are specific treatments that we use for tuberous sclerosis, as well as more evidence that we can use some anti-seizure medicine to prevent the development of seizures in tuberous sclerosis, which is exciting because we can be very proactive about it. So just some other features aside from those tubers I was talking about, or some of these other tumors within the body. You get these changes in the retina called achromic patches, or even small tumors in the retina itself. And then some dermatologic findings, which are often the clue for some of us that are looking at babies trying to diagnose why spasms have happened. If they didn't have a prenatal diagnosis, sometimes things like these ash leaf spots can be helpful. These angiofibromas here, or the shagreen patches, tend to occur in older patients, but it's really some of these skin findings which are very helpful in an infant that we're evaluating for spasms. Neonatal HIE, or hypoxic ischemic encephalopathy, is another important cause of infantile spasms. And what HIE is a syndrome of an abnormal neurological exam in the newborn period, usually associated with a baby that's had a difficult birth and requires respiratory support after they're born. And there's evidence of ischemia to the body or to the brain, and often seizures in the neonatal period. And long term, this can result in global developmental delay, cerebral palsy, and significant disability. And we have neuroprotective treatment that we give these babies when they're born, and we recognize that something may have happened and their neurological examination is abnormal. And that's therapeutic hypothermia. Some of you may be familiar with it, where we actually cool the baby for 72 hours in order to minimize the amount of inflammatory brain injury from the decreased delivery of oxygen to the brain. It also helps in reducing seizures. And the idea is that, and in studies, it has shown that the hypothermia treatment can decrease the rates of death and significant motor disability. Unfortunately, it has not impacted epilepsy outcomes. And so there's a large proportion for the population of these babies that go on to develop epilepsy after the newborn period. And many of those babies present with spasms first. So there's some data here to support that about a third of patients in the neonatal seizure registry in HIE had infantile spasms. And then we also showed with my colleagues at Cornell, and this has been substantiated, subsequently, that it's injury to the deeper structures of the brain, the basal ganglia and the brainstem, that were predictive of infantile spasms in a predictive model to figure out which babies were at highest risk. So that's much more established now. And so there are certain types of injury that we see on an MRI after we've done the cooling treatment where we can tell families this is something to watch for. I'm not going to spend a lot of time on this slide. It's a little bit of an alphabet soup, but I just wanted to put it up there that there are many rare conditions that we look for routinely when a baby presents with spasms. Some of these are blood tests or urine tests that can tell us that there's a rare metabolic condition where the brain is not getting energy that's appropriate for it. However, the body is processing various fats, proteins, and sugar. There's also specific genetic conditions that we're able to diagnose, not only with chromosomal testing, but with next generation sequencing and single gene disorders on epilepsy gene panels. Many of these we're able to send in the NICU or in the clinic pretty readily now. And some of them, like the last line I have there, also involve structural brain disease. So the interlay between a genetic condition affecting the structure of the brain, as well as some of the epilepsies that might present when babies are first born, which are very rare, but do present with spasms much of the time. So when the spasms are identified as seizures, when we've identified that a baby is having spasms, we see the movements, we're concerned about them, we get you an EEG as soon as we can, and we diagnose that the movements are seizures, and there's a background brain activity that's not normal, and maybe hypsarrhythmia. There's a lot of testing that's done, and there's variation in centers. And I think a lot of that variation in some ways came out of the pandemic when we were trying to keep kids out of the hospital. And so at least at Maine Med now, we try to do as much of the workup as we can as an outpatient, just because of resources. But where I was before at Lurie Children's, you would get an automatic admission to the hospital. We would do a prolonged inpatient EEG, and then we would facilitate your workup. So this varies from place to place. Certainly at Boston, I'm sure that's what they're doing. I'm very familiar with what they do, but it's a little bit different depending on where you are. The mainstays of it are that you need to have a prolonged EEG where we understand the background of the brain waves as well as what's happening during the movements, and we confirm spasms. We need an MRI of the brain to understand whether there's an anatomic or structural brain difference that's leading to the spasms. Expediting the genetic testing I talked about. And then some testing related to the treatments we might consider. A big one is an echocardiogram where we're looking for the baseline heart structure, because if we start steroid treatment, which is our first line treatment for spasms, we want to ensure that there's no heart enlargement prior to doing that. Some centers will also do chest x-ray to ensure that there's no active lung infection, because some of our medications that we use are immunosuppressive. And so we want to make sure that we have a baseline for all of those things. So if a family comes into the hospital, there's a lot of testing that's done just at the outset to figure out, are these spasms, and then what are we going to do about them? And then generally, after the diagnosis is made, there's multiple EEGs in close succession. And that's done generally as an outpatient in a lot of places. So in our protocol, we will do another EEG in 2 weeks, and then in a month, and then generally for the first year or so, every 3 months after your diagnosis. We want to keep an eye on those brain waves. We want to make sure they're stable, that the spasms aren't coming back. And then the important piece of all of this is that there's an open line of communication with a pediatrician or PCP and pediatric neurology, because there are so many medical things that we need to be watching for during the treatment and when you're off the treatment. And so, and I'm going to talk a little bit about what those are, but having that open line of communication and the collaboration is really important. And I always tell my patients that I'm like, I really want to make sure your pediatrician's comfortable with what we're doing. And I think a lot of pediatricians welcome that, because this may not be something that they see. I see it all the time, unfortunately, but they may see it once in their career. And so if you as a family or parent are concerned that there's not that open line of communication, we need to ensure that that's something that you feel you have and advocate for that as well. So the goals of treating infantile spasms, we want the spasms to stop, and we want that background brain activity to also get better and to normalize. And that's not always true of all types of epilepsy. There are some, epilepsies where we know we're not going to change the background, but we can at least minimize or decrease the seizures. But we really want to do both in spasms. The first round of treatment generally works in 40 to 80% of patients. So that's about half of patients that are going to respond, and their spasms will clear with the first treatment. It's 1 in 3 will relapse or just not respond at all. And so that's why it's so important to follow closely, not just after diagnosis, but on treatment and then after treatment is completed, to just ensure that we're not backsliding in any way in terms of the brain waves or subtle seizures. The response to treatment is dependent on the cause. So if you have a structural brain difference, you have an underlying genetic cause, one of these rare conditions we've talked about, it is harder to gain remission. And we just need to identify that as as fast as we can, as easily as we can, and set that expectation that there may be multiple rounds of treatment for us to get this under control. Unfortunately, the prognosis is generally poor overall. These numbers come from putting all of the cases together. So they're high percentages. Now, there are a proportion of patients in whom we never identify an underlying cause, and there's not a lot of developmental delay, or it resolves, and there's no structural brain injury. Those are called idiopathic, and those babies have the best chance of cure. But unfortunately, those are a minority of patients. So 25% of patients after spasms have a decent long-term cognitive outcome, and only 30% have long-term seizure freedom. Up to 85% have developmental delay, and a very high proportion develop other types of seizures and epilepsy. And this old paper reported mortality quite high. I would say that that's a little hard to assess given that we monitor patients so closely on treatment now, and we are doing better at identifying underlying causes. But that was the quote from 1988, and I think that's just important to highlight that that is a consideration. But there are some favorable aspects of prognosis. So the earlier you get those spasms and start treating them, the better. The faster we can get your brain waves out of the hypsarrhythmia state, that's great. And then being aggressive with treating any relapses that happen. And that might mean multiple courses of steroids. I'm going to chat with you about that, or other types of medications. So the first line gold standard is hormonal therapy with either injected ACTH or adrenocorticotropic hormone or oral prednisolone. Now, in studies around the world, it has been thought that the injectable ACTH is superior to oral prednisolone. There's a little bit of debate about that. A lot of centers consider them equivalent, and at Maine Med, and we were also doing this a bit in Illinois, we will often start you on the oral form first because we can get it started quickly. With ACTH, we have to go through a lot of insurance hurdles. It has to be shipped to you. There has to be training involved in how you administer it. It's a needle for a month every day, up to 4 times a day. So it can really be a lot. And so we want to get this started right away. And if what we'll do is start the oral treatment, monitor you in 2 weeks with an EEG, and then if we need to, we will then escalate to the ACTH. So you may come across that with your own experience or with talking with families and peers. Oh, I wasn't started on the injectable. Well, sometimes it is stepwise, and every center is a little bit different. But this is one I'm most familiar with from a lot of the places I've worked. The idea behind hormones is that it suppresses a lot of excitatory neurotransmission in the brain. So people don't quite know how it works, but there are some substances that are in the endocrine system, which actually are seizure-genic, so to speak. They're proconvulsant, and this is suppressing that. There's variable steroid protocols, even among US centers, but also around the world. But for the most part, you're going to be on steroid anywhere between 2 to 6 weeks. And there is usually a high dose protocol for 2 weeks, whether it's oral or injected, and then a taper off over the subsequent 2-ish weeks. So that's a long time to be on steroid. The reason we only do it for that amount of time is because we want to minimize side effects, which can be very significant for babies and families. So again, hormonal treatment, ACTH is generally considered the most effective. And then in this Dr. Knupp's paper here, there was a 55% initial response. So that is like our best chance. It's still only half a response the first time around. But what I like to tell families is I like to hit it hard and fast and be aggressive with it. And then we're going to tailor this to what we need to do for you. So common side effects. This is the bear. This is a really tough round of treatment. We can run into high blood pressures, and so blood pressure needs to be monitored very closely during treatment. If babies develop elevated blood pressures, we will put them on a little bit of an antihypertensive until they're off the steroid. Babies can be immune suppressed and at risk for infection. And so we cannot have them get any live vaccinations for 4 weeks, no vaccinations during the duration of treatment, and then you are considered immunosuppressed for several months after treatment. So that can affect, where families go. Are they going to be traveling? Like, who can visit the home? I ran into that a lot over Christmas, right? We had to have some conversations with families about what types of visitors could they have over. And that's hard. It's impactful, but in the long run, it really is, for safety. You can run into electrolyte disturbances, so we do check labs every week when you're on steroids. And for the most part, that's looking at the potassium and the sodium and making sure those are at normal levels. Reflux, gastric irritation, changes in stool patterns are all really common. And it's also babies get super hungry, they get roid rage, they gain weight, they retain fluid, and that's all temporary, but it's just confined to the steroid course and then the wean and then the resolution of the treatment. But the idea behind using steroids only for several weeks is to minimize the amount of time that these side effects are happening and also to minimize the immune suppression specifically. Vigabatrin is another medication that we use frequently, and this is the one that's considered a first line for tuberous sclerosis complex. In studies, those children responded very, very well to Vigabatrin as a first line treatment, response rates of greater than 94%. We can use it as first line in other causes as well, causes of spasms as well. Although many centers again will choose to use steroids, or there is a practice to try to use Vigabatrin and steroids together as a first line treatment, so combination therapy. And that's something that has been studied in Europe and has been adopted by some centers here. We were doing it frequently in Chicago, but in Maine, due to concerns and challenges with getting ACTH readily, I tend to do the oral steroid form first, unless you have tuberous sclerosis, and then we would go straight to Sabril or Vigabatrin. Just an important thing that there was a study, EpiStop, showed significant decrease in the rates of development of spasms and epilepsy when babies were treated before their first clinical seizure. And so this is a study showing that there was prevention of the development of epilepsy in a short-term period. And so that's really exciting in terms of trying to actually prevent, the development and then the subsequent challenges with control. There are some significant side effects of Vigabatrin as well. Most commonly, it's fatigue and sleepiness. And for those children that have low tone, you can sometimes get a little floppier. And that is something that we need to just balance with doing therapy and being kind of on this for some short course of time. There is a black box warning for this drug, which if you're familiar with it, you might certainly have heard about it, which is to say that the FDA found that there was a loss of peripheral vision, which is irreversible. Certain vulnerable cells in the eye were affected by this medication. The way that we deal with that is to monitor with serial ophthalmologic examinations. And if there's any concern for changes to the peripheral vision, the medication is discontinued. There's also a very rare syndrome where babies can have more of a movement disorder and some changes in some of the deep structures of their brain as a side effect of Vigabatrin. This is very rare. I have seen it, but it's quite rare. And we stop the medicine when this occurs. But the thing that is most concerning, as you might imagine, to providers and families is this vision issue. But it's actually quite rare. And what I like to tell families is, at this point, I've probably treated hundreds, if not, I don't know, I wouldn't want to say 1,000, maybe I'm not that old, but hundreds and hundreds of babies with this medication. I've never seen any visual field loss in children. A lot of these studies were also involving adults, and I think that's where they were able to identify that more readily. So I do try to reassure families that this is an incredibly safe and effective medication for spasms. So word about the ketogenic diet. This is actually also a treatment that is used in some centers very early on in spasms treatment course. So ketogenic diet is a high fat, low carbohydrate diet, which is shown to reduce seizures in all ages. And there's varied forms or recipes of the ketogenic diet. The medical ketogenic diet is the one we use for epilepsy in infants and children. It has been shown through the group, predominantly at Johns Hopkins, that it is actually a very successful initial or next line treatment in infantile spasms. So if you get steroid treatment or Vigabatrin, and then you have a recurrence or an incomplete response, there are some centers that will go right to ketogenic diet from here, as opposed to adding a standard anti-seizure medicine. And what they found is that you can actually reduce anti-seizure medications when you're on the ketogenic diet. And that's true also of other types of epilepsy, but they showed it in spasms, and then sustained improvement in development, as well as improvement in the EEG. There's just some, statistics there for you. Common side effects are GI related. So any patient on the ketogenic diet can get constipation, have worsening of the reflux, as you might imagine, because it's a very high fat diet. They can get irritable. There's a risk of kidney stones, and so we do watch for that. We do labs, and we can start you on some supplements to prevent that. And long term, there's been shown that there may be reduced linear growth if you're on ketogenic diet for a long period of time. The idea is that this is food as medicine. So we're using your food to treat you, and sometimes it can be complementary to the medications you're taking. And in some cases, you can come off some of the medications and just be on diet. So it's nice because it really can not only control seizures, but can also improve alertness and behavior. And so there's a host of things that improve with ketogenic diet. So we have started a pediatric ketogenic diet program here at Maine Health. I run the clinic along with Kelly Falone, who is my partner in crime, dietitian. And, we're really excited to be able to offer this treatment to people here in Maine and parts of New Hampshire. Obviously, we will also partner with Boston Children's. I have had some patients who've been on keto a long time, but they live far away from Boston. And we've been able to sort of take over some of the nuts and bolts of monitoring and sort of the day-to-day management of keto. It's important to know that in younger babies, there's actually ketogenic formula. So a lot of families will ask, well, how do you do that when a baby's on formula? There's a specific ketogenic formula. It's called KetoCal. And there's other tube feeds, if necessary, that we can make keto friendly. And then in older children, even toddlers, there's ways to make regular food that they like ketogenic and keto friendly. And it's fun because you can really be creative with what children like. And it's all about just kind of learning how to make food that way. So there's a lot of education that takes place, but it's a really great collaboration with the team and a lot of close communication and partnership. The way we often do keto, just to kind of give you an overview of how it runs with us, is you would meet me and I'd kind of learn about your epilepsy, and then we would figure out whether this is something you want to try to do. And then we do a big education session in the outpatient setting with myself and Kelly, my dietitian. And if the family or the patient wants to go forward with keto or another one of our diet therapies, such as modified Atkins or a low glycemic diet, then we will, for the keto diet, we will actually bring you into the hospital and do the initiation, which is something that most centers do, where you are monitored, the blood sugar is monitored. We teach you how to weigh food. We teach you how to, start kind of proportion out meals, and you just kind of monitor for tolerance of the diet, the side effects for the child or the patient. So it's usually about a 3-day stay. And so that is something that a lot of centers do. With some of the less strict diets, you can do some of it at home to start. But anyway, we welcome inquiries. We'd love to have more people to work with. So don't hesitate to reach out if you're interested in keto here in Maine. I just wanted to chat real briefly about epilepsy surgery for infantile spasms. So we know that in patients whose brain structure lends itself to potentially having a surgical cure of their epilepsy, that we should be doing that in as early as possible, even in young children and babies. And so when spasms are caused by some sort of focal structural injury to the brain, it becomes very important to think about epilepsy surgery as a potential cure. So just as an example, I'm going to show you here that this is from a neonatal stroke. And this is just another example of that with the sort of some of the networks and the diffusion of the brain. But this is also not just related to stroke. Some of those tubers from tubular sclerosis, other malformations of cortical development or structural brain differences that a baby or child was born with. Some of these things can be amenable to surgery. And again, there's just evidence that specifically when some sort of focal injury to the brain has caused spasms, which involve the whole body, that surgery can cure them. So just when you're working with an epileptologist or a neurologist, we at Maine Health, we are not an epilepsy surgery center, but we work very, very closely with the folks in Boston and are able to send patients down for their epilepsy surgery workup and surgery, and then they'll come back to us for the remainder of their care. But it's a really open line of communication. So definitely something to always be thinking about if it's right for you and your family. You can talk about that with your epileptologist. So I really love this little graphic because it really kind of sums up what we're talking about when we want to identify spasms early. So I always welcome video consults, whether you take a video of a movement you're not sure about, it seems odd, babies do all kinds of funny things, and sometimes we're all puzzled by them, which is how we get you to the EEG if we think there's something that might be going on. But early recognition is the key for improving outcome. So it's see the signs, these clusters of repeated uncontrolled movements like head bobs or crunching, take a video. Pass it on to your pediatrician who will find a neurologist, or if you know a neurologist, send it to them. We do e-consult at Maine Med as well. So if you have a video, you can pass it on to your pediatrician and they can send it through MyChart right to us and we can make a determination. So, time is brain, really. We want to get this identified as fast as we can. So obtain the diagnosis, confirm your irregular brainwave pattern, and then prioritize treatment. And again, the goal is to get the treatment as quickly as possible in the right form, in the right way, in order to optimize our chances of stopping the spasms, but also preserving development. And I know that Christine's going to have all kinds of great resources for you guys, but I really love infantilespasms.org. That's where a lot of those videos came from. Of course, the Epilepsy Foundation has so much great information. For those in whom it's appropriate, TSC or TS Alliance is fantastic, and then Cure Epilepsy, but I'm sure there are many others that you might have access to. And I think that's, oh, thank you so much. And I would love to take some of your questions, and it looks like we've got some time to do that, so. I'm gonna escape here.
Thank you so much, Dr. McDonough. I have a question. I'll start it off. So when a child has one of the spasms, do they become irritable after the spasm? Do they become fussy and kind of after it? Is that like a postictal kind of piece to the spasms?
Yes, so they definitely do become irritable. And that's one of the things that parents bring up a lot is, they're just out of control. They're crying all the time. So we don't think that spasms themselves are painful, but they might surprise the baby. We don't think they hurt, although it's hard to know. But what happens is as a cluster goes on, babies do tend to get more and more irritable. And then in general, they just seem like more irritable and not themselves during the evolution of spasms. And the other thing is if you're on steroid treatment, that's probably one of the biggest and worst side effects is the behavior changes. One of the biggest challenges for families is the sleep dysregulation on spasms, as you might imagine, or on steroids rather. As you might imagine, we're like just amping a baby up with high doses of steroids. Like I said, roid rage, right? And that's what happens. And so it really does disrupt sleep. But only for that period of time when we're on the treatment can we attribute it to the spasm or to the steroids. So I always like to tell families we're going to power through. It's going to be okay, and sleep will come again. But we just have to kind of, go through these like 4 to 6 weeks of of really tough treatment.
Anybody else have any questions for Dr. McDonough that is here tonight? If you want to, you can unmute yourself as well. You don't need to put it in the chat.
Hi, I have a few questions.
Sure.
So, I thought it was really interesting, the ketogenic diet. I didn't know that was even an option. So, assuming a child or an infant gets placed on that, how long are they expected to stay on that diet?
That is a great question. We know that you can be on it a long time, but we tend to use it just like any of our standard anti-seizure medications. So we kind of have a general rule of thumb for 1 to 2 years of treatment, generally 2. So if we start it, the minimum that we'd want to do the keto for to demonstrate that it's effective, because it can take some time, just like any of our medicines, is anywhere from 3 to 6 months to really see that we've decreased seizures and we're improving other things, such as development, alertness, engagement with therapies and school. But generally, the rule of thumb out of Johns Hopkins is like 1 to 2 years of treatment. And then you can try to wean it off if you have had good seizure control.
Thank you.
I have had patients on it much longer though, and they've
Oh,
been,
okay.
yeah.
Gotcha. Also, so, every time that a seizure, is it more common when, like for it to be while they're sleeping? Like, can that happen a lot more, or is it mostly just like when they're more like alert, awake?
With spasms specifically?
Yes.
Yeah, so spasms don't tend to happen when babies are asleep. Rather, they happen sort of in that drowsiness zone of waking up. That's where the
Oh,
brain just tends to make spasms more frequently, and then falling asleep. So we call it the sleep-wake transition, and that's generally when the spasms happen. They can definitely happen when babies are awake throughout the day, but it's that drowsiness piece where they tend to happen the most.
okay. And then my last question, do they usually last those spasms the same amount of time, or as it, I guess, not necessarily gets worse, but as it continues, does it ever get longer in between?
You mean in terms of those clusters?
Yes.
Yeah, clusters can be really variable, but yeah, if spasms were coming and they weren't being treated, the clusters do tend to get longer and longer until treatment is started. Yeah,
Thank you.
you're welcome.
Just for clarification, when you say treatment, are you talking about starting them on a regular routine, like you said, or would you use like your typical seizure rescue medication for these clusters?
For clusters? Yeah, that's a great question. We don't tend to, very, very infrequently do we recommend using like your standard rescue meds for the clusters of spasms. There are some situations where maybe that's appropriate, but for the most part, because the seizures themselves are so short, we aren't as worried about them being dangerous per se as a long seizure that's continuous, where we want you to treat it at 3 or 5 minutes, because it then becomes harder to stop with our regular medicines. But clusters of spasms, it's actually just individual seizures that are just going on a while. And so we generally don't have you do something like Diastat or Valtoco or anything of those rescue medicines that we use for older children and adults.
So if a parent has a question about these, so let's say, a new parent has an infant and they're concerned that something is off, what are the first steps that they should be doing, Dr. McDonough? Like, what would be the first steps as a parent? So they're noticing these odd behaviors of their child. What would you recommend would be the first steps for this parent to do?
I think if you're noticing the abnormal movements, you can always take a video of. And then the first step would be to just talk to your primary care provider, provide them the video, and they will generally get us involved if they're unclear about what things are. And even if they feel like it's, something they're not sure about, we do have a very open line of communication with a lot of our affiliated pediatricians. And so we receive videos all of the time. I encourage people, take the video and show it to your pediatrician. And then again, if we decide this is suspicious and we may not be sure whether it's something like reflux, but it looks suspicious for spasms. And as I showed you, some of the spasms can be pretty subtle. We'll have a very low threshold to get an EEG. So we don't withhold or feel like the testing is it's invasive, because it's not. It's literally just an external recording, and we'll try to capture the movement and ensure that it is something or that we need to treat you right away. So first step, I think, is take a video and notify your PCP.
Thank you so much.
Hi, I have a question. Thank you so much for your time, first of all. My question is, when a baby is displaying these repetitive movements during the clusters, do they typically display one specific movement throughout those clusters, or is it just simply repetitive stereotypical movements, if that makes sense?
Sure. Yeah, no, it does. So there's a lot of variation in what spasms can look like. And I hope some of those videos helped you sort of see some of that. But the key is that the movements that the baby tends to make tend to be pretty consistent. So even though some babies might just have a subtle head drop, it might be more prominent over time within the cluster, but it's a very similar type of movement. Same thing with that baby that was like doing the grimace. It was such a stereotyped grimace, as opposed to I'm fussy and I'm doing all these other things. So I guess if I'm answering your question right, what I'd say is that the movements can look like all sorts of things. The common thing is flexion of the body or extension of the body, or some sort of crunch, repetitive, stereotyped muscle contraction. And it usually within that cluster is very consistent.
Oh, that makes sense. Thank you. A follow-up question regarding that. With these specific movements, are they related to specific parts of the brain in terms of when you're head nodding or when you're doing the fist clenching? I'm just curious because I'm not really sure.
Yeah, no, that is such a great question. We don't think so, because most of them involve kind of the core of muscles, whether it's the neck or the trunk or some parts of the extremities. And the brain patterns are what we call generalized. So they're coming from deep within the brain and spreading very rapidly throughout the brain. So it's a little bit different than some of our focal seizures, where that spikes on this side are going to do this here. So great question. It is a generalized type of seizure, even though it's very, very short.
Awesome. That makes sense. Thank you so much.
Thank you, Dr. McDonough, for joining us tonight. We so appreciate you being here. I want to remind everybody that our doctors that join us every Wednesday have donated and volunteered their time to be with us. So they're not getting paid to do this. They're so graciously taking personal time away from their families to come and join us tonight. And we're so grateful, Dr. McDonough, for you being able to spend your Wednesday night with us and explaining and educating us more about infantile spasms, because I definitely learned a lot tonight. So thank you so much for joining us tonight and being here as well. We so appreciate it. I did in the chat put a bunch of resources. So I have saved the chat, so I'll make sure that that does go out to everybody tomorrow. Also, the last piece I put in is our survey. So if you have a moment just to fill it out, it just gives us an idea to make sure that we are on the mark, that we're doing the best for you and our families and our patients, so that we are meeting your needs. We want to know. So please take a moment to fill that out. If you have ideas on future topics, we definitely want to know that. But Dr. McDonough, we are so grateful for you being here with us tonight. And thank you so much for being here. We truly, truly appreciate you being here with us tonight.
My pleasure. Thank you, guys.
Thank you so much. I want to wish everybody a wonderful evening, and we look to hopefully seeing you next Wednesday night at our next Wednesday webinar series, and we'll be emailing you more information about that as that comes up. Thank you guys so much, and have a lovely evening. Thank you again, Dr. McDonough.
Good night.
Bye-bye.